Hello, I'm Norman Swan. Welcome to this programme about self-harming behaviours in adolescents. And we're coming to you on the Rural Health Channel. I'd first of all like to acknowledge that we're broadcasting from the land of the Wango people and the Darug tribe, traditional custodians of the land and part of the wider Aboriginal nation commonly known as Eora. And we acknowledge their elders, past and present. Self-harming behaviours in adolescence are commoner than you think and are hugely misunderstood. They're often missed, and when they are found, health professionals don't know what to do, and there's either inappropriate panic or inappropriate action or reassurance. The results of not intervening in the most effective way affects the young person, their family and the school, sometimes quite destructively. So it's good you're watching, whether you're a teacher, a health professional or a family member. You can ask questions or make comments by emailing to questions@rhaf.com.au. If you're watching this programme live, do join in. You don't have to be a health professional to be part of this programme. And you can text us on 0408 408 932, or you can phone us on 1800 817 268, or you can fax us. Remember what fax machines are? If you still have one of these ancient devices, you can fax us on 1800 633 410. And I stress, you don't have to be a health professional to join in. Any one of our viewers here on this station can actually join in. If you are a health professional, this Rural Health Education Foundation programme offers accreditation and continuous professional development opportunities. And we'll talk to you more about that later. Unfortunately, if you're just an ordinary member of the public, you don't get any of these advantages except the fantastic information we're about to offer you. But let me introduce our panel to you. If you've not watched the programme before, we tend to do this by a panel discussion and raising issues, usually around real stories of situations which arise in the problems that we're talking about. Caitlin Seymour is a youth advisor at Headspace in Albany in Western Australia. Caitlin is working with the Headspace Youth National Reference Group and her local centre helping young people. Welcome, Caitlin.
Good evening.
Sandra Radavini is a consultant child and adolescent psychiatrist, the clinical director of Headspace, and is also director of Mindful at the University of Melbourne. Sandra was also the first chief child psychiatrist in Victoria with their Department of Health. Welcome, Sandra.
Thank you, Norman.
What is Headspace?
Headspace is the National Youth Mental Health Foundation. It's for young people 12 to 25-year-olds. We have centres across Australia, an online service and also a school support for particularly schools where there's been a suicide. So this topic tonight is very pertinent to our work.
So what does Headspace actually do though?
We provide mental health services to young people. So that might be young people who have got worries about depression or worries about relationships or drug and alcohol concerns, worries about their schooling. Can be a little problem, can be a bigger problem.
We'll come back to more of that later. Vicki Ryle is the manager of eHeadspace. Vicki has an extensive experience in clinical work with young people and also management within youth mental health organisations. Welcome, Vicki.
Thanks, Norman.
So eHeadspace is virtual headspace, is it?
Yeah, that's exactly
Online.
right. So we're trying to, well, we are providing a clinical service. So we've got youth mental health professionals providing live web chat and telephone support or email support to young people right across the country. So some areas of the country there's not as good access to services we would like, and young people are comfortable in the online environment, so it's working really well.
So there's a lot of online therapy now. There's Mood Gym and various organisations have where you can go in and do your own therapy online. Is that what you're offering through eHeadspace?
It's an important thing that you ask actually, because there's sort of automated tools that people can use that are, I guess, like a game, if you like, but that are actually taking them through.
Well, some people think they're better than psychologists.
Well, I guess the evidence is not quite there yet, but there's some evidence.
Don't want you to be doing you out of a job here.
Yeah, that's right. What we're actually doing is we've got mental health professionals responding via live web chat or telephone or email. So really trying to do almost exactly what we would do in person, but online and on telephone.
Andrew Channon is our last member of the panel, not least, Associate Professor in Youth Mental Health at Origin Youth Health Research Centre and the Centre for Youth Mental Health at the University of Melbourne. He's also Director of Clinical Services at Origin Youth Health and a consultant psychiatrist at the Adolescent Forensic Health Service in Melbourne. Welcome, Andrew.
Thank you, Norman.
Andrew established and directs the Helping Young People Early programme, that's HYPE, clinical research and training program. Just tell me a little bit more about HYPE.
It's a
We'll have no HYPE today.
Yeah, well, it's named HYPE actually because of all the hype around self-harm, in fact. And we are an early intervention and prevention program for severe personality disorders, particularly borderline personality disorder. And so self-harm is a common feature that brings young people to our attention.
And in today's programme, we're actually going to talk about personality disorders a little bit later. And again, if you're not a professional watching, you may recognise some of these features and a light bulb will go off. So I urge you to stay on and hear that. And the other thing that I thought we would do tonight is actually talk about real stories, suitably disguised so that the identities of the people we're talking about are not obvious, but really get into real stories so that we understand the issues with people who self-harm and typical stories, because, Sandra, they're often missed.
They often are. What comes to mind is a young person called Danny. I'd like to start by talking about Danny.
Not his real name.
Not his real name, of course. So he was a young guy, 14. He repeatedly came to casualty departments. He was admitted to intensive care a couple of times, and it was because his diabetes was out of control. And every time the diabetes would be stabilised, his mother would be given advice about dietary things, he'd be told what not to do, and this was escalating. He was presenting more and more frequently with his diabetes out of control. And of course there was another story behind the sort of the medical problem. And the story behind the medical problem was a very tragic one. Danny had lost 2 brothers to suicide. He'd actually found one of his brothers who had hung himself.
Oh no!
And
what age was he when that?
It was about a year earlier, so he was 13 when this happened. He came from a family where there'd been domestic violence, a family where you didn't talk about problems, and his mother was now petrified that she was going to lose Danny because, of course, his diabetes was potentially very serious and out of control, and she would sit by his bedside, literally watching him breathe. It was a terrible scenario.
So she almost had anxiety disorder, if you like, as a result of his problems and the situation in the family.
Well, her anxiety was realistic, Norman.
So did she recognise, so the subtext here is that the diabetes being out of control was his self-harm.
It was. It was.
Did anybody recognise it as that?
I think people knew the story. They knew that there was these tragedies in the family, but I don't think they linked them to the the diabetes being out of control for Danny. Eventually, though, in desperation, a referral was made to the mental health service that I worked in, and for us to try and see, could we understand this? Could we help Danny? Could we help Danny's mum?
Did his mum recognise it as self-harm?
No, she didn't, not at the time.
Did Danny?
Danny was a young man who actually didn't say very much. He was polite, but it wasn't possible for him to actually talk about what had happened in the family or to talk about the diabetes. He'd just politely go, yep, I know that, yep, I know what I'm supposed to do. And at the same time, there'd be the 2 litres of Coke sitting there, and he'd be drinking Coke non-stop all day, despite his brittle diabetes.
So you made the assumption it was self-harm?
Well, we came to understand it that way. We didn't know in the beginning. We got this referral of this young man who was doing something that was quite dangerous without understanding why.
But so how did it help defining that as a self-harm?
It was around understanding what was the intent behind this out-of-control behaviour with respect to his diabetes. And what we came to understand was that Danny was feeling pretty hopeless. He'd lost 2 very important people in his life. He actually thought he'd rather be dead. He'd rather join them. What was the point of being around? And so his view was, I don't care what happens. I don't care what happens to me.
Slow suicide?
You could put it like that, yes.
So how at risk was he? Because he actually hadn't committed suicide in the sudden and appalling way that his siblings had. How... I mean, it goes to some of the myths that are attached to it. I mean, I might come to you, Andrew. I mean, what are the myths that people feel? And we'll come back to Danny's story in a moment.
Well, one of the myths about self-harm is that it's always done to annoy people, to frustrate people, or that it's a deliberate choice. Another myth is that it's always associated with mental illness. It's not always associated with mental illness, particularly single episodes of self-harm, or with borderline personality disorder, which is another disorder that people often jump to thinking about with self-harm. And importantly, it's not just a fad. It's something that is a serious problem, a serious mental health problem, and is a red flag for an underlying problem.
How could it not be related to mental illness? That just doesn't make sense to me.
Well, up to about 16 or 17% of the population will tell you that they've harmed themselves at some stage.
Deliberately?
Deliberately harmed themselves. What distinguishes people with mental health problems is actually that it's more recurrent, and there's good research now to show that recurrent self-harm is much more indicative of underlying pathology than single episodes. Now, you might be seeing somebody on their first episode of a recurrent pattern, but someone in front of you who has only ever harmed themselves once is clinically different to those people with recurrent self-harm. What you often find is that people who present will give you a history of self-harm that hasn't been detected, or they haven't presented to clinical services for help anyway.
We've already had one question come in, and it's from Jenny from Inverell in New South Wales. Can a self-harming adolescent become a self-harming adult? Vicki?
Absolutely, sometimes they do. Sometimes it becomes a way that people learn to manage how they feel or punish themselves. And I think one of the things that we also know is if people can get help, then we can teach them other skills and learn different ways to manage things, and we can intervene in that. But certainly it can go on to become an ongoing problem for some people, as Andrew's saying.
Some self-harm is self-limiting though. In fact, the majority of self-harm is self-limiting, that from puberty you get a rise in self-harm and it tapers off then in the 20s. And whether it becomes enduring or not often depends on the response of the health system.
Caitlin, do you find that when you're talking to young people who self-harm, the people that you're mentoring and so on, that they are frightened they might go on to adulthood, that they're trapped in this behaviour?
I think so. Sometimes it might feel like there isn't an end in sight for this kind of coping mechanism, or that there won't ever be a better way for a young person to cope with that. But I think that often that's not the case, and that you'll find that with the appropriate help that they can find other ways of coping.
So what do you think of Danny's story?
Well, I think that it highlights that it's not always obvious. Like, self-harm isn't always what people might think of cutting or that sort of thing. It can come in various forms and might not be so easily detected. I think he might not even know why he's doing it himself, and not think of that as self-harm. But it's obviously a way of saying that he's quite distressed and
lonely. He'll be quite isolated. And
lonely and in need of some assistance.
So, Sandra, what did you do for him?
Well,
You took a deep breath there.
I did take a deep breath. First
It
of all,
wasn't easy.
it was not easy. This was our involvement with Danny and his family, I think, went on for about 18 months. What we were trying to do, we were trying to make sure that Danny was as safe as he could be. We tried...
Was the abusing male out of the picture?
Yes. Yes, that was in the past, so that was no longer an ongoing concern. So we tried to look with Danny about how could he keep himself safe. The rest of the medical profession was saying, you should do this, you should do that, you shouldn't be eating this, you shouldn't be doing that. That was just going in one ear and out the other. And so we were trying to go...
Because he probably knew all that.
He did know all that. He'd been told numerous times. It's like when you tell a young person, oh, you should just stop cutting. Well, it serves a purpose, and so you can't just stop cutting. Danny couldn't just stop doing what he was doing because there was something behind it. And I think for him, there was enormous grief behind what was going on. There was trying to cope with that grief, a grief that couldn't be expressed. He couldn't talk about his brother's suicide.
A grief that's hard to get over.
Absolutely. but certainly by yourself, if you have no way of putting it in words, if you have nobody that can help you do that, then you're left with having to display your grief and your distress in other ways. And that's really how we understood Danny's behaviour.
I wonder, Sandra, would you say that this is an example of one of the common reasons that people self-harm, which is self-punishment, which is it sounds to me like
he was feeling guilty that he was alive.
that he was guilty, punishing himself for being the survivor.
There was elements of that, Andrew, because Danny did think a few times, well, if only I had gotten home, why didn't my brother tell me? Obviously, he was actually the youngest of the brothers. So some of his guilt was unrealistic, really, but nevertheless there for him, that maybe he should have known, maybe somebody should have done something.
And I think what's often significant for young people like Danny is a relationship with someone that's enduring, that becomes a safe space to express some of the more difficult things to say. And that can take a really long time with some young people.
And it did take a long time with Danny. It took a long time before we could go anywhere near talking about the tragedies in the family.
So in Hollywood movies, when you're having psychotherapy,
yes,
there's a light bulb moment,
yeah,
you know, the cathartic moment, and tears come in the eyes, and the whole problem gets resolved. I assume that's bull dust.
Well, it wasn't the case for Danny, that's for sure. It could happen some of the time that people do have moments when they become aware of something and things make sense in their story, in their own story for them, but it usually is a pretty slow process.
So, and can I just say that it also takes practice. The aha moment might happen for some people, and does happen reasonably commonly in psychotherapy, that someone will go, I never thought of it that way. But actually then to change takes incredible practice, and particularly if you're self-harming, because people become very adept at it, they become very habituated to it, and it becomes a powerfully self-reinforcing behaviour. And
what do they get out of it?
Well, they actually commonly report that the majority of people who self-harm will tell you that they self-harm to regulate their emotions, that they have overwhelming, difficult feelings, and they do it to manage these difficult feelings. A lot of people...
So they feel better once they've done it?
They absolutely feel better. And in fact, there's one of the theories is that there's a release of endorphins, the body's natural opiates, that actually make them feel better. There's also evidence that they will tell you they don't feel pain when they harm themselves, but also there's scientific evidence to show they have a higher pain threshold, so they can cut themselves without feeling it, and often quite deeply.
Is that what young people tell you, Caitlin, your peer group?
Yeah, I think so, and I think it's quite evident in someone who might have been self-harming for a period of time that it kind of gets more sort of severe, and I think that's part of that.
But this notion that you feel good.
That you feel...
Do you ever feel good when you do it, or you just feel better, less bad? I mean, what's the story?
I'm not sure. I think that there's obviously something that keeps drawing people back to doing that, and they might feel good from it, or they might be getting something else out of it.
Norman, it can act... Sorry, Kate,
that's okay.
To cut across you. It can act like a distraction. I start to have worrying thoughts or worrying feelings or memories.
So it's like having an elastic band on your wrist.
Exactly,
that you flick. Yeah.
Exactly. In fact, that might be one of the things that you might suggest to a young person. Can you do something else that's a distraction that isn't as harmful as whatever the other behaviour is?
What we would want our health professionals to do is ask. I think
So there's a belief that if you ask, you're going to make it worse, or you're going to put the thought in people's head.
We're really confident that that's untrue.
So do you ever self-harm? Have you ever thought about ending your life?
And could you tell me about what that's like for you, and what it's like after?
So somebody's watching this programme who's not a health professional, and they think, well, what if I come across somebody at work or in my family who I think is really at risk? Can I, what Pandora's box am I going to open up by asking this question? And it's really quite scary, but how safe is it for somebody who's not a professional to ask that question of somebody?
I think information is helpful. I think it's a great question because I think unhelpful responses to, are you hurting yourself, if the person's going to say yes and the person who asked the question is going to freak out or something, that's not going to be helpful. But
But it doesn't happen very often.
There's other ways to show that you care and ask and perhaps, you know, give some information, look up some information with people. You know, there's some good information around this now.
The important thing here is non-judgmental inquiry into, and it's very hard when it's someone you love who you're seeing hurting themselves. But
you're not going to induce the situation by asking the question.
No, you can induce it with an inquiry that is highly emotional, critical in particular, and one that induces shame or humiliation in the individual.
So, act it out for me. Tell me what that sounds like.
Well, it would be, Vicki, you're not hurting yourself, are you? That's terrible. You shouldn't be doing that. You know I've told you not to. Whereas if you calmly say, I've been noticing that you've actually been covering up your sleeves lately and wonder what's been going on. In which case you then elicit some discussion about it without the kind of overly dramatic response.
Now, later on in the programme, we'll actually give you some tips about where you could go for help, either as a professional or indeed as a non-professional, just so that you can guide people to some extra help. Now, Vicki's school son, you'll find this hard to deal with as well.
Yeah, that's right. And it might be helpful to use an example, but a 17-year-old young woman I saw who'd had quite a long history of depression and self-harm, and historically an eating disorder. But she'd been hurting herself by cutting and overdosing, small non-lethal overdoses, which she took both the overdoses and the cutting for the same kind of reasons. When she was overwhelmed, usually in response to a fight with parents, partner breakup or friends. And certainly there was one instance that stands out in my mind where she had hurt herself. It had been in the toilets at school. She had a couple of friends with her. One of the friends saw the whole event and the other one went to get help. The teacher that...
And there was a lot of blood, presumably.
Yeah, I didn't ask, but I would imagine so. But one of the friends saw the whole thing and was pretty distressed. The teacher that arrived first was a recent graduate, was incredibly distressed.
So they did something like, you know, Andrew just acted out, where they heightened the emotionality of the whole thing.
Yeah, I mean, I think they went procedural and, you know, rule-based, to be honest. At the time, I don't think there was any emotional support. They probably felt terrified, but what happened was more rules. She was taken to the principal, she was sent home. It was more like a telling off response, which is critical as well. And then, you know, I got calls saying we can't let her back. I remember really strongly...
Why?
Policies around, and I was asked to guarantee all sorts of crazy things, that I would be able to respond in certain times, that she wouldn't do it again ever, things that I couldn't possibly, as her therapist, guarantee. But the school was scared, and her parents were scared and angry with the school, angry with her. And she became, you know, well, stuff that, I'm not going to go back then.
And the underlying reason here was what? She
was overwhelmed. She'd had a fight with a friend, and there was a test result that she'd done. She was a very good student, and she got, I think, a B instead of an A, so and then had a fight.
There was an issue about an unusual way of coping with stressful situations.
Yeah.
And maybe an immature, you know, slightly naive personality or something like that.
She'd had a long history. Her self-harming behaviour was quite well entrenched, as we've talked about. That was how she managed those difficult situations.
So what did you do for her?
I spoke to the principal quite a lot.
So you gave the principal a good talking to?
The principal
Put them in the corner.
Was great, actually. We were really lucky in that instance that I think I said something along the lines of, can I be really honest with you? I think it would be unhelpful to not let this young woman continue her schooling and finish this year. So how can we make this work? But
they would have been worried about the risk level. How well are you? So let's say somebody watching this programme sends their young child or their child in for help, you know, or takes them in. How well able are you to assess the risk so that there's not an overreaction of fear, but also not an underreaction?
It's a very good question, and it's a bit of an inexact science. I'm sure Sandra and Andrew might want to jump in, but I mean, we do the best we can. We've got good information about risk, as in history of risk is a good indicator to predict future risk. So we always try and understand what someone has done in the past.
And presumably if they've got major depression, that's another issue.
Yeah,
impulsivity is a big thing. If somebody's got a pattern of impulsivity and a history of deliberate self-harm, that's the greatest risk. Those two risk factors combined pose the greatest risk. But that's a lot of people, and suicide is a comparatively rare outcome. So you're still trying to detect needles in haystacks, and as Vicki said, it's an inexact science.
So Caitlin's school story, again a common story, that there's a problem with the school because of self-harm?
I think definitely. I think I can think of a couple of cases where there's been self-harm in a school, and one case in particular, that school decided that they would either suspend or expel this student. I think schools are quite scared of dealing with.
And I remember actually, I saw her the next day. I had an appointment in the young woman I was talking about before, and I was sent an A4 sheet of paper that had, I don't remember the number, but about 20 things that I was to guarantee, which I think was an education department document, I'm not really sure. And I can absolutely understand the usefulness of it for them, and perhaps even why they do it. But from a mental health perspective, it doesn't sort of make much sense.
So did you manage to sort her out? Did you manage to break the habit?
She stayed at school, and by the time I finished seeing her, she wasn't self-harming.
And what made the difference? Just taught her new ways of coping?
She was very motivated to make things different, and she had in fact been decreasing her self-harm. That wasn't my goal, to stop her self-harm. We were trying to reach... Well, I guess I was trying to address her underlying difficulty. She had depression, and she had a history of personality disorder as well. So I was trying to treat those things.
Let's get some questions, because you've already sent in some questions. Frank from, so Chris, a high school teacher from Canberra, asks, is there any advice on overcoming privacy issues when dealing with self-harm students? Is balancing the right of parents to know and students to have privacy and trust? Can you get a balance there?
Yeah.
Actually, I might ask Caitlin that about privacy, and then come to Sandra.
I think that you need to discuss privacy with the young person, and try and get the family involved where possible. I think that the best way, well, one of the best ways to recover is when you have a family or you have a support network behind you. So if the parents are involved, it would help. But I think you need to see what issues there might be there, and why, if the young person doesn't want the parents involved, why?
Because you might have an abusive situation at home.
An abusive situation.
What do you think, Sandra?
I think sometimes it could even be simpler. I don't mean simpler isn't quite the right word. It could be a bit more straightforward, that when you do ask young people sometimes, why don't you want me to talk with mum and dad about this? Sometimes they're worried about mum and dad's responses. You know, mum's going to cry, dad's going to be angry. I know that sounds simplistic, but I'm going to have to deal with their emotions as well as, and their disapproval, as well as trying to manage the stuff that I'm trying to manage.
So it's not really a box called privacy, it's a box called there are issues in here
Things
which
are going
we actually
on.
have to tread carefully.
And when it comes to the confidentiality, there's no such thing as absolute confidentiality. You balance confidentiality against risk always.
And also making a statement to the parents. Often people neglect, they explain about confidentiality, but they neglect to reinforce to the parents that if there were a situation of risk, that would always override confidentiality, and that you would breach and make sure they knew what was going on.
Frank from Parks in New South Wales asks, are there medications that people can take to help? Andrew?
The short answer is no. That in fact there are very few studies of medication directly for deliberate self-harm. However, treating the underlying problem is important, and that often does involve medication. So for example, one of the commonest causes of self-harm is depression. And treating depression, which often involves the use of antidepressant medication, does result in a improvement in self-harm. Rarely also self-harm is caused by psychotic disorders, so disorders like schizophrenia. And in fact, the more bizarre the self-harm, the more likely the person is to be psychotic. And again, treating the underlying problem will resolve the self-harm.
Deb from Hobart asks, are there any initiatives in teacher education to training student teachers to help look after young people with possible self-harming?
I don't know about in universities as part of educating yet to be or, you know, emerging teachers, but certainly Headspace has a school support initiative which, as Sandra said, is focused on schools affected by suicide, but there is also some prevention training that will be rolled out across the country from the Headspace School Support Program. Prevention
training? How do you prevent this? I wasn't aware there was any evidence that you could prevent this.
So what some of the training is focused on is looking at schools, looking with schools at the kind of policies they have about helping them think through ways that they might want to manage self-harming
So you've got a
behaviours.
situation, how do you stop it getting worse and how do you deal with it with
yes,
a fellow child?
And arming people with information and them feeling more equipped to manage the situations as best they can.
Simon, a nurse from Alice Springs, asks a really good question. Do adolescents ever purposefully seek others who also self-harm? In other words, forming a partnership that supports each other's behaviours. Caitlin?
Well, I think that often you hang around people who understand what you're going through, and if there's someone who's going through a similar situation, you can definitely relate to them and therefore...
Well, that's not what Simon's asking. I mean, my understanding is that, like with eating disorders, you can go if you go in a search and look at self-harm, like eating disorders, you'll find websites that look as if they're going to be helpful, but in fact they encourage your anorexia nervosa and teach you ways to actually hide it from your parents, you know, bulimia and so on. In this case, self-harming behaviour, they're almost like how-to websites.
Oh yeah, definitely. There's even a risk in trying to seek help and coming across the wrong websites, or you know, it's definitely, if you are around that behaviour, or you see that behaviour in someone else, it's possible that it could trigger you to self-harm.
Self-harm or find new ways of doing it.
To find new ways of doing it.
So people need to be aware that those websites are out there. So can you ask, I mean, it's a fair question to ask, what websites you've been looking at and that sort of thing?
Yeah, I think definitely it's a fair question to ask. I think also the finding these websites is inevitable, and seeing this thing.
So give you strategies to deal with them.
Yeah, I think it's more important, like it's out there in the media, and I think it's more important that's followed up by a positive message that you know. And I've found recently in the lead up to this, if you search, there's often like the Headspace website and the Lifeline website will come up with
so you can divert people to
keywords
other more useful things.
Yeah, I think so, and I think it's more. I think it's about trying to have more positive stuff than negative stuff out there in the media.
As a clinician though, you can go on the front foot and warn people, you know, or discuss with people, you're going to find this, how about we discuss it? Because otherwise that becomes another covert behaviour as well.
But, you know, we've been talking about sort of, you know, in the stories so far, kind of hidden problems, but sometimes they're not so hidden and they're still ignored by the health professionals.
Yes, and I think this is the majority of the problem actually, that covert self-harm does occur, but it often doesn't present, and by definition you're not going to get the opportunity to do anything about it. People present to emergency departments every day. Most self-harm is known and intentional. It is actually, another name for it is deliberate self-harm. And so people harm themselves and present for medical care, and often the focus is on repairing the damage but not actually searching for the underlying problem, and it's a highly charged environment in emergency departments. Certainly one young person that I recall who would present repeatedly to emergency departments, suicidal, having cut themselves very deeply. People would focus on the stitches, getting them sutured, getting them out again because this person was disliked. But of course nobody talked to her about what was going on, what was the problem that precipitated the self-harm. Once she was discharged from the emergency department, she'd go out the front and promptly remove all the sutures, represent to the triage desk and get an even more emotional and angry response from the emergency staff.
So what's going on here? I mean, that while you say the cry for help is one of the myths, that does sound like a cry for help, and yet not so able to hurt themselves, but not express what they need.
So the cry for help is not a complete myth. Self-harm has meaning, and we need to understand the reasons why people self-harm in order to be able to assist. But it's often such an in-your-face, overwhelming experience as a clinician, not well taught in medical schools, not well taught in nursing, and in fact the culture that is carried among health professionals is one of stigma and discrimination against people with self-harm. So you're not likely to get modelling from your mentors and your peers as to how to approach this in a calm and sensible fashion to look for the underlying problem.
So what did this young person want when they went back into the triage nurse having taken out the stitches?
Well, there were various things, but it would often be about loss of somebody, perceived abandonment from somebody. When she felt that some relationship was going to break down, she'd become highly emotional, highly distressed, and the only way she could manage those feelings was to cut herself.
And so, sorry, Norman, so she gets, when she goes to casualty, she gets her suture or her laceration attended to, but the other problem remains unattended.
And nobody's in fact asked her what's going on, how did you end up hurting yourself today, or what?
And it's also about how you go about doing that, and you need an environment of trust, and you need an environment where people are non-judgmental and you can feel that they're really wanting to assist. And casualty departments.
So let me put myself into the role of the emergency nurse or the emergency physician. I ask that question and they give me an answer and I haven't got a clue what to do.
Indeed.
That's my fear.
Yes.
So I don't ask the question.
That's right. And
so let's. I'm actually getting anxious just thinking about it. So I ask the question and they say, well, things are crap at home. I did badly in my exams today. And I've done this before and it all seems hopeless. What do I do next in emergency? Or the GP, or the practice nurse, or the school nurse?
I mean, I would imagine that one of the things that we would hope happen next is, asking about, have you done this before? Do you have people that you talk to about this? So to actually very first understand what supports are in place currently. Because often, I mean, lots of the people that we've seen in public mental health would be going to emergency or going to a GP, and there's a range of things already in place.
I'd also be looking for symptoms of a treatable mental disorder. So what often gets overlooked is history taking, mental state examination, and a simple assessment of what the problem might be. Lots of problems that present to emergency departments, emergency physicians are not equipped to engage in the long-term treatment of those problems, but it seems that this problem gets caught up in the kind of emotional response such that they don't take actions to refer people to appropriate care, and also the opportunities for referral to appropriate care are very patchy. So I can understand their frustration. I think it's wrong to just point the finger at emergency staff. They're busy, they're hothouse type environments, and somebody coming in with this kind of problem is overwhelming, and often the resources are difficult to find. So I don't think it's a one-sided issue.
And you can see how someone presenting to an emergency with who has deliberately harmed themselves versus someone who has come in with a medical condition that's seemingly from some people's perspective, one could be within someone's control and the other one could not be. And you can see how it would be difficult, and also in that case of the person undoing the work that doctor had done, it would be frustrating for ED staff and difficult to treat that one over the other.
I can see that, but I also don't think they have the same attitude toward obese smokers, for example, who come in with heart disease.
I wouldn't bet on that.
Yeah, well, I don't think it's quite as strong, the emotional and the emotional response. If someone comes in having an acute myocardial infarction, they would usually get on and treat it. But the experience of some people who recurrently self-harm is they present with severe self-harm and are turned away or treated badly by staff.
Andrew, we had at eHeadspace, we had a young woman in the last week log on, and she was talking about her self-harm and that she's been self-harming for the last 5 years, and she recently attended a casualty department where a doctor said to her, well, I'm not going to stitch that, you've just done that to yourself. And it's trying to get understanding the frustration, and I agree with you about the frustration, but it becomes a value judgment of who's worthy or not worthy. And in fact, everybody's worthy, and young people who self-harm, this is an important red flag of there's something not going right for this young person.
And we in fact know that unhelpful responses are unhelpful, that it can actually make people worse. So it's not to blame people for what they do, but
So you could push them over the edge?
No, but it can make their recovery more difficult. So the first time people disclose self-harm, it is actually quite important how it's responded to, or certainly, as Andrew said before, that it's responded to with empathy and a non-judgmental attitude, because, you know, the reverse is quite unhelpful. And it may make it go underground or people hide it.
So it's trying to stay calm, trying to say, well, let's think about what we can do to help you, let's see if we can understand this, let's find out what's out there, and assisting a young person rather than an idea. Again, we're talking about young people who, by and large, are not great help seekers about anything.
And I think the most helpful thing, one of the helpful things that I find in encountering people who harm themselves, is to remind myself this is the best that they can manage at the time to cope. And it's not very good, it's not very helpful, and it makes other people angry and frustrated, but it's the best they can manage. They don't have any other cards in their hand that they can play.
So Caitlin, you're involved in Albany in Western Australia, country town. What is it about a country town that might make this harder or easier?
Access to services. I think in Albany we're fairly lucky to have a Headspace centre in our town, but in a lot of regional towns we don't have that option, and obviously things like eHeadspace have come in, which is the Headspace's online and telephone counselling service, have come in to sort of try and help with that, but it's very difficult to access services in Albany, and then if you go even more regional and rural, there's not 24-hour emergencies and that sort of thing. It's sometimes very difficult to even.
You're watching a rural health broadcast here on the Rural Health Channel, and we're talking about self-harm. This is an open discussion to health professionals and non-health professionals, so don't feel at all shy about phoning in with a question, and we'll put the numbers up on the screen in a moment. We don't have long to go in the programme, but we'll be very pleased to receive any questions at all, and in particular from general members of the public. I just want to get to some of the formal stuff about self-harm. What do we know, Andrew, about the reasons?
The reasons that I outlined earlier are the general reasons why people self-harm, mainly emotional regulation, mainly self-punishment, and then a range of other reasons. Influencing other people's behaviour is a reason that people self-harm, but it's not the common reason at all, and people overemphasise.
What do you mean by that? I'm sorry.
Well, trying to get something from someone else, trying to influence a relationship, or trying to gain something from somebody. Emotional blackmail, I guess. But that's actually not the most common.
Self-punishment for what?
Well, often people who are prone to self-harm actually have an innate self-critical voice, an innate, are highly self-critical in the first place. They're also
they're perfectionists?
They can be perfectionists, yes. They're mainly high in a trait called neuroticism, which is a propensity to have negative emotions, particularly mood and depression and anxiety. And so they're prone to these negative emotions, they're highly critical, and that's a fertile ground for self-harm.
Where does borderline personality disorder fit in?
So borderline personality disorder is one of the cardinal symptoms of the disorder is recurrent deliberate self-harm or threats of suicide.
So in other words, not everybody with self-harm has borderline personality disorder, but if you've got borderline personality disorder, you will
almost everybody with borderline personality disorder harms themselves
in some shape or form.
In some shape or form.
Just describe the person, because when you hear the description of somebody, you know somebody with it. So just describe exactly in somebody.
So it's a disorder that involves when the person's usual pattern of thinking and feeling and behaving is characterised by difficulties regulating their emotions, inappropriate anger, and also...
So they fly off the handle for no good reason?
No good reason, yeah. And they also have impulsivity that's usually self-damaging. So they'll engage in impulsive, unsafe sex, impulsive drinking, impulsive spending, driving, the kinds of things that are likely to get them into great difficulties.
And their attitudes towards other people can turn on a sixpence. I mean, in other words, they love you one moment and suddenly, for no reason, they just hit you the next.
Yeah, so they have very unstable interpersonal relationships. They also have an unstable sense of who they are as well. So their identity is highly unstable.
So they're thin-skinned.
They can be thin-skinned, and not in the way that people who are narcissistic are kind of prone to be insulted by other people, much more in the way that they're emotionally attuned, highly sensitive. It's like they have no skin emotionally. They have no defences. So they're very attuned and very prone to quite subtle interpersonal cues that will trigger an emotional outpouring that is very difficult to then manage, and it's often that they self-harm in response to those difficult to manage emotions.
Can it be treated?
It absolutely can be treated. That's one of the good news stories about evidence-based medicine in the last 20 years, that there are now a range of treatments for borderline personality disorder that are effective.
They're psychotherapies, they're talking therapies.
They're all psychosocial treatments, and in fact the evidence is hardening for the fact that there is very little role for medication. This is a group that often end up having inappropriate prescribing, polypharmacy.
So if you take 100 young people who are deliberately self-harming, what proportion of that 100 would have a borderline personality disorder?
If they're recurrently deliberately self-harming, then it can be up to 50%.
50%?
Up to 50%.
So it's not a myth?
No, it's not a myth at all.
Depression? How many have got depression?
Is the vast majority of those other people. For single episodes of deliberate self-harm, it's actually not commonly borderline personality disorder. So I'm drawing this distinction between single episodes and recurrent, because the more recurrent, the more likely it is to be borderline.
And risk factors? What are the risk factors? What creates risk here?
I think we have to look at, the classic is biopsychosocial. We have to think about biologically, have we got somebody who has a predisposition to a mental illness like depression? From a psychological point of view, the traits that Andrew was talking about, somebody who is prone to be pretty negative in their thinking style. From a social point of view, what's going on in the person's environment, their family? Is there a history of maltreatment? Is there a history
of physical and sexual abuse are risk factors?
They are risk factors, yes.
Can I
not totally.
It's one of the myths about borderline personality disorder and self-harm in general, that physical and sexual abuse are definitely risk factors, but they're actually risk factors for a whole range of mental health problems. They're very non-specific for self-harm, and in fact they probably are a marker of a common underlying vulnerability.
Can I ask a question, Andrew? With regard to borderline personality disorder, is there a perception that that's the go-to diagnosis for a young person?
Well, it's a good question, because it's changed over the last 10 or 15 years. I describe it as the diagnosis that dare not speak its name. That, early on, people were very reluctant to make the diagnosis. The tide is turning, though. People are more willing to make the diagnosis. The evidence is actually quite overwhelming in favour of the validity of the diagnosis.
But I think what's sitting behind Caitlin's question is that you could overdiagnose it.
Yeah, I don't think there's a risk of overdiagnosing it at this stage. I think that, like all these things, you can end up with epidemics of it. It does have defined operational criteria, so it's difficult to make up the diagnosis.
Except I think Caitlin's saying Is there a danger?
You're putting words in Caitlin's mouth here.
Oh, no, well, I might be. But Caitlin can correct me, of course.
Sure.
What I think Caitlin was saying is, can it look like, you know, self-harm equals borderline?
Oh, sorry.
Well, and was that
did you
what you
mean
were
that?
saying, Caitlin?
No,
Oh.
I think, but partly, but I think also, like, sometimes when diagnosing a young person, you might be looking for a diagnosis.
Yep.
So, you know, like possibly, you know, that person has adjustment disorder, or that person has borderline personality disorder. Is it a sort of a when there's no other diagnosis?
A refuge when you haven't got anything else to go to.
Is that like the refuge diagnosis?
It's one of the criticisms of borderline personality disorder as a diagnosis in and of itself. The research is now pretty clear in adults and increasingly clear in young people that it's not a wastebasket diagnosis, it's a valid diagnosis in its own right. And an important one, because actually the treatment is quite different to the treatment of depression, bipolar disorder, all the
So
other
getting
things.
to the bottom of things is really quite important.
Absolutely.
Ben from Townsville asks, is there any evaluative data on the impact of bullying on social media on increase in self-harm, and has there been an increase? Do you know the answer to that?
I don't know about evaluative data, but certainly it is increasingly common. Cyberbullying is common. There's a lot of discussion to distinguish bullying and cyberbullying, but let's, for the sake of the conversation, think about them as sort of similar. And I think it is one of the social factors that Sandra mentioned that we would want to think about. And one of the other things that has come up before is, do peers groups who might all self-harm congregate together? And of course social media facilitates that. So because we know that people may come together around a particular topic, you mentioned anorexia or eating disorder behaviour, self-harm, so the social media can facilitate those things. What we try and think about at Headspace is using the internet for good and not evil.
Yes, which is what Caitlin was talking about.
There are some data, Norman, that on bullying, and it's actually quite a specific association between bullying.
So there is an association.
Yeah.
Well, I want to ask, because we've got other things to get through and we're running out of time. Cindy from Victoria, in Hamilton in Victoria, wants to know, how do you help a family member who is self-harming? Do they have a higher likelihood of self-harming if you try to help them?
I'll start by saying...
I suppose, is there a risk you do the wrong thing, I suppose? If I can go into Cindy's mind, is there a risk of doing the wrong thing?
I think families or particularly parents are very anxious about their young people, and so they're worried that they're going to do the wrong thing. But in fact, not talking about things, not addressing things, there's a much greater risk of harm from not doing things than there is from trying to be non-judgmental, supportive, staying calm, and basically saying to a young person that you care about them and you want to be with them and try and get them some help.
And in your experience, how good are GPs at this, if the family decides they're going to seek help from the GP?
Oh, it's like everything else, you know, there are going to be some good GPs who have experience in this area and will manage that well. There will also be GPs who will be overwhelmed by this kind of presentation and who won't know what to do. And as Andrew was saying, who may not have options for where they can refer either, and it becomes anxiety then provoking for that GP.
I think it's important to say though, if you are not equipped to deal with self-harm with the person that you're talking to, you can ask the question, but be prepared for the Pandora's box to open, and then also be prepared to go and
help them get help.
Help them get help, and also seek advice about how you might be able to help them. I think that there was...
So why don't you choose that opportunity now because we've got some resources we can advise people on. Just tell us where people can go, particularly online.
Sure. Well, Headspace has a really good website with a lot of mythbusters and sort of fact sheets about self-harm. There's also Beyond Blue. Origin have a good website, and also Mental Health First Aid. But if it's an emergency, I think also contact Lifeline or Kids Helpline.
Justin from Burleigh Heads asks, is it difficult to recognise self-harm amongst international foreign students whose first language is not English? Have you got any experience of that, Vicki?
I mean, I've seen a lot of international students in different workplace settings, and some with interpreters and some without. I don't know that we find it more difficult to assess, except the usual complexities of using interpreters in any assessing any problem.
Behaviour. Antoine for Wagga asks, do self-harmers ever, it's a good question, ever purposely harm others? Sandra?
Again, it depends on what the underlying difficulty is. So the answer is yes. Sometimes people will take out their aggression towards themselves, and sometimes they're at risk of hurting other people, often people close to them rather than random people.
So that's the old story of stigma.
Yes.
Which people get frightened about,
yeah.
and
stigma, we haven't actually, it's the first time we mentioned stigma, and I think this is really important because it gets in the way of help seeking. It makes it really hard if a young person is worried about, well, what does it mean if I go and tell somebody that I'm doing this? What are they going to do? Where are they going to send me? What's going to happen? And, am I crazy? Are people going to look at me differently, deal with me differently? So that whole area of stigma is a big, big barrier to help seeking.
And some consumers make the point that this is outright discrimination, not stigma, and that it's probably more helpful to think of it that way.
What I've heard so far is that the ramifications are enormous. You've got schools who don't know what to do and overreact. You've got parents, we've heard stories of parents just being scared to death that their child's going to commit suicide. And what's the statistic? 4 times more likely to commit?
4 times more likely.
So that is a real issue,
yes, it is.
The progression to suicide, and you've got to do something about it. What we haven't talked about, we've only got a minute or two left, is treatment. We've talked about borderline personality disorder and depression. So I assume that we're talking about treatment is that there's not one catch-all here. It depends on what the problem is. Is that right?
Absolutely.
There's certainly treating the underlying disorder, whatever is diagnosed, but there are some approaches that are called transdiagnostic, is the catch phrase, that are cognitive behavioural based. But there's a whole range of treatments, and the good news story is, again, that there are a range of treatments, and that often consumers want choice. They don't want just one treatment shoved at them regardless, and there's a range of evidence-based treatments that are helpful for deliberate self-harm.
And I think it's also important just to remind, obviously, it seems fairly obvious, but that we would always try and create safety and intervene in physical, where someone needs help, like stitches or something, before we would then go along to some psychological
So safety
treatment.
first, you're saying, Vicki?
Yes.
Yeah.
So what are your take-home messages, Andrew?
To recognise self-harm, to take it seriously, to look for the underlying cause, do a basic history and mental state examination.
So this is for the professional watching?
For professionals. So to take it seriously, look for the underlying causes and treat them. For people at home is to be, and for everybody in fact, is to be non-judgmental, respectful of the person, recognising this is the best that they can manage, and the best that they can manage is not helping them.
But sometimes you're going to have to accept that you're not going to get an answer immediately, and you're going to have to live with a bit of risk in your home.
Absolutely. You need to learn to tolerate looking at a young person self-harming, tolerating some of the difficulties in order to eventually reduce the risk. It's one helpful way of thinking about it is that you've got to take some risks in order to reduce risk.
Hard message for families.
It is, and it's very anxiety-provoking for families. I have a family at the moment who I'm dealing with who are having tremendous difficulty accepting that because they're absolutely convinced this young person is going to die at any moment, and their efforts are actually making that more likely.
By doing what?
By not letting the young person learn new ways of coping, by reinforcing hospital as always the answer to every episode of self-harm.
Briefly, your take-home message, Vicki?
I think for health professionals to involve parents, for parents to look for information with your young person and try to, educate yourself so that you feel more confident.
Sandra?
For me, it's health professionals being aware of their own emotions and their own responses so that they can be aware of that, think about how they deal with it, and then they're better able to help a young person by trying to stay calm.
Caitlin?
I think that for someone who's not equipped to deal with self-harm, to go and get help for yourself and for the person that you're trying to help.
Thank you all very much indeed. And I hope you've got a lot out of tonight's programme, as indeed I have. If you're interested in obtaining more information about the issues raised, you can go to the websites that Caitlin mentioned, or you can go to the Rural Health Education Foundation website, rhef.com.au. Click on the programme on self-harm and you'll get those links and others. If you're a health professional, don't forget to complete your CPD evaluation form, which can be completed online. You'll receive a certificate of attendance and, if eligible, CPD points. If you're not a health professional, you don't get all those benefits, but you get the benefit of the wonderful information. This was sponsored by the Department of Health and Ageing in Canberra, and thanks to them for making the programme possible. It was good to have your company tonight, and if you want to make a comment, please email us. Join us again on the Rural Health Channel. I'm Norman Swan. Bye for now. The Rural Health Channel broadcasts 24 hours a week. To see what other programmes are showing tomorrow and for the rest of this week, go onto the Foundation's website and click on the RHC TV guide on the left-hand side.